So I'm only going to take 2 or 3 minutes just to really go over the program itself, and we'll jump more importantly, I think, into the case study with Sandeep. But the program itself, so we are a NHS England funded program. So we're running partnership with the 15 health innovation networks and lots of other different partner groups across the NHS and the ecosystem. So we run a 3-year fellowship program, um, really for the brightest and best of digital health innovations across the country. What we concentrate on is really within the SME space, so similar to sport to the health innovation networks, mostly software as a medical device and kind of back end non-clinical efficiency solutions as well. We do some med tech as well. So, for example, Cited with the Cited sponge, some of you may have heard of that one, but we don't generally touch therapeutics or kind of the larger scale EPRs, for example. We're very much kind of focused on the SME space. What we try to do with these companies is really 3 things. So it's curating, it's guiding, and it's connecting as well. So curating, the role of the program around curating of these innovations is really for the benefit of systems themselves and local system partners within trusts, within ICBs, wherever that may be. And it's really trying to pick out what are the most exceptional innovations on the market at the moment that are working somewhere in the NHS, and how can we tell you about them? So to get onto the program, you need to be live in at least one NHS site. And that's kind of outside of a pilot phase as well. And what we really try to do is pick out the solutions that are working at a local level, and then how can we expand them from local level to regional to then multi-regional as well. Really picking out what's working, what do you need to know about it, and then presenting it to you guys. And that's hopefully one of the things we'll go through today. There's also the guiding part of the program as well. So the guiding element is how can we take innovators through the complex NHS market? So there's 2 elements to that really. There's the learning program that we do, and these are quarterly and also kind of bi-monthly events that we have with everyone. And we focus on a really well thought through and put together learning program, which covers everything from health economics, evaluation, health inequalities, procurement, patient public involvement as well, really guiding them through masterclasses. And we've developed what we call a maturity matrix, which we're starting to roll out into the program, which is really focused on how can we get these companies from stage A to stage B to stage C, which is really everything that the NHS would need to see from these companies when it comes to all those parts. So, for example, evidence evaluation and public patient involvement, for example. One of the other parts that we really want to do when it comes to the guiding of the innovators as well is the other stage of the quarterly events that we put on, which are really focused on connecting them and helping senior leaders from NHS England, Department of Health and Social Care, and actually from systems as well. So whether that's kind of CCIOs or chief financial officers from ICBs, really coming in and telling them exactly what is it that you guys are focused on at the moment and what can they do to best help and serve those needs of the system. Again, it's important to highlight that we're 100% NHS England funded. So this program is specifically for systems and the NHS itself. It's not for the innovators itself, but we can really we can get a win-win situation if we can get these companies to exactly where the NHS needs to adopt them at scale. And then finally, it's connecting. So that's connecting these proven innovations to the NHS, so based on system pool. So it's likewise what we're going to hopefully try and do today with Romecare, but it's also at the policy level, it's at the NHS England leadership level as well. It's with Department of Health and Social Care. It's really making sure that they're connected into everything that's happening from funding, for example. So you probably were all involved with HTAF last year. We had some influence at the beginning of it, but we really tried to make sure that fellows on the program knew everything they needed to know as and when that came around to make sure that they were primed to make the most of that. Just some really quick numbers about the program. So this program's been going since nearly 10 years now, since our 10-year anniversary. The fellows on the program are spread to over 3,250 plus sites, about 1,000 new roles created. So some of the companies you probably would have heard of or are Doctor, Patients Know Best, Nerve Centre, Sleepio, Open Medical. About 75 in total have gone through the program. We've got about 30 on the program within the current years 1, 2, and 3 at the moment. Now, the important part to really get into as well is the assessment process. So, as I said at the beginning, a lot of this program is around curating the brightest and the best of the digital health space at the moment. So the application process remains the same, and we're really trying to do a lot of the due diligence that you guys would have to do when it comes to procurements or kind of horizon scanning at the beginning for you to really identify a list of here's what's working, as I said, within the system at the moment, and then how can I adopt that within my local sites. So I'll just walk you through the assessment process. So we have an annual application that opens every year. Do this in September, the same time every year. Our applications are reviewed by clinical experts from across the NHS. So we try to get anywhere between 3 to 5 experts to review each application that comes in. So those experts are generally, they're usually CCIOs, are quite a few of them, depending on the application that comes in, what therapy area it's working in. We sometimes have all the way up to kind of national clinical leads or medical directors have a look at some of the applications, but generally it's on the more on the ICB level. Once they're reviewed, the applications are then also reviewed by NICE and other national bodies. So that's the National Health and Equalities team, so Balola Wabi's team, the Net Zero team from Greener NHS as well, all do a informal review of these applications. So they don't give us formal guidance, for example, like an EVA or something like that, but they will give us a steer as to, is this something that we should be taking on and what's their opinion on it. Once that's been conducted, the applicants are then invited to an interview panel. So that's a panel of commercial, clinical, patients, and implementation experts. And again, we have CCIOs, we have clinical leads on there. We also have commercial experts from health innovation networks. We have third parties as well, like Health Foundation. We're looking to get involved in this year's too. The numbers that generally come in have about 150 applications every year, and about 20 or 30 get to interview. And once those interviews are conducted, we then have our final review board, which is the NIA board, which is chaired by Stephen Powis, and we have a number of kind of NHS England senior leadership on there as well, like director of Accelerator Access Collaborative, for example, and a few chief officers of health innovation networks. We also have representation from the National Health and Race Observatory and also the Health Foundation. References are finally requested from each fellow as from their actual provider sites, which have already commissioned them. As I said, this has to have already been used in the NHS to actually get onto the programme. And then finally, we conduct some due diligence with some more partners like the Crown Commercial Services, for example. So we make sure that they're on all the relevant frameworks and they hit the standards needed to be able to be adopted immediately. And then finally, we do some financial and also some cybersecurity due diligence, including DTAC, and all the normal ones that you would expect to come with IG. And then we finally launch it. So it's a really long process when it comes to the due diligence side. But what we're really trying to achieve there is making sure that the companies that come onto the program hit the standard needed to be able to be scaled within the NHS. And anything that they don't quite hit, we can then have a clear plan over the 3 years that they're with us that we can work with them on. And as I mentioned, one of the key things we're really trying to do is pick out what's working and then how can we highlight it in the system. So not just show you this is what's working in the NHS at the moment at a local site, but also how did that happen? So what was the implementation journey? Where did the budget come from, for example? What staff were needed to actually implement this? What was the journey I had to do to convince, for example, the CFO in my site to actually get bought into this?
So I think Jack's already introduced me. I won't go through too much. I'm still a practicing orthopedic surgeon, and RemCare is a product of a desire within my own clinical practice and a few of my colleagues to streamline perioperative pathways to make it much more patient-centered and more efficient. And I'm grateful for this opportunity to present in front of you. I'm also very grateful for Barry Lambert from Birmingham Children's Hospital, who's the lead anaesthetist there for preoperative care, who'll be talking about the RemCare implementation, Birmingham Children's, and also we're also joined by Maggie Babb, who is the anaesthetic lead for the West Midlands Surgery in Children Operational Delivery Network. So I'm going to set a quick scene about what problem RemCare is solving in perioperative pathways and how it can help in provider systems in streamlining the pathway and increasing the productivity while improving patient outcomes. And then followed by Barry, who's going to talk about the local implementation of RemCare in Birmingham Children's Hospital. And following that, Maggie is going to talk about her, the West Midlands Surgery in Children audience ambitions of having a cloud-based regional platform to streamline the perioperative care for children across the whole region. So while RemCare can cater for adult and children's perioperative care, this talk, we're going to focus on the children's side of the whole situation. So if I can start off by defining the problem we're trying to solve in the form of a case study. Please meet Jack. He is, Harry, who's a 7-year-old boy who's on the waiting list for a tonsillectomy. Unfortunately, he has got a long wait ahead of him. And during this wait, his condition deteriorates. He is visiting his GP for several antibiotics. He's also visiting A&E on a number of occasions because of worsening episodes. And all of this causes severe anxiety to the child and the family, several days of school, days of work for the family, and Harry is getting quite sad with this. Now, most children's, the APA, Association of Pediatric Anaesthetists of Great Britain, stipulates that every child should have a pre-assessment before coming in for surgery. And the situation in the West Midlands is that a lot of hospitals do not have a robust pre-assessment service for children. And in those hospitals where there is a pre-assessment service, it is often short of capacity. And Harry, as a result, doesn't get a pre-assessment before his surgery after a long wait. And he ends up on the day of surgery with severe anxiety, which requires a physical restraint, and all that leads to a very poor patient experience, but also causes delays in theatre because of the anxiety issues, and in turn, theatre utilization problems. So effectively, there is no significant harms review currently in most systems to detect whether patients are deteriorating while they're on the waiting list, which affects patient outcomes. And there isn't enough capacity in pre-assessment services to prepare every child for surgery. And where there is a pre-assessment service, most systems have, a same pathway for every child, regardless of the risk profile. And this is really not customized to the risk profile of the individual child, which leads to unnecessary appointments for low-risk children and a high and resource deficit for those like Harry who absolutely need the service. So how does this pathway look with RemCare? So what can good look like? So essentially, once Harry is put on the waiting list, if a hospital is using RemCare, we can pull all this data about Harry from the trust IT systems through an integration, or pending the integration, the whole waiting list can be bulk uploaded on RemCare, which is a web-based platform with a patient app and a hospital dashboard. So as soon as this waiting list details are entered on RemCare, the platform already automatically sends an SMS and an email with an activation link for the RemCare patient app, which the families can use to log on to the RemCare app. They can also use the NHS login credentials. We're already integrated with NHS PDS Spine, so the data is validated. And once the patient and the family get onto the RemCare app, they fill out a detailed questionnaire asking about their condition and their health status. And the unique aspect with RemCare is, compared to any other system which can collect patient information remotely, is the algorithms on RemCare automate some decision making, in that they can automatically look at all this the data and risk stratify patients into not only just low to high risk groups in terms of their health status, but also any pre-optimization issues in the case of Harry, an anxiety issue, or even some health inequalities. And all these questionnaires and the risk stratification can be customized to local hospital specifications. On the app, Harry and his family also get useful information in terms of the procedure, counseling for anxiety, all of that is available. And following that early risk stratification, which will guide any proactive interventions to prepare this patient, this is followed by 3-monthly contact with the patient, where a separate set of questionnaires are sent out, which are specifically customized for that individual specialty or condition, so that in this instance, any deterioration Harry has noticed in his condition can be again automated. And this is again displayed in a patient timeline in the appropriate color-coded dots, so that even non-clinicians can notice that Harry's condition is deteriorating, so that this can be highlighted to non-clinicians, to the clinical teams, who can prioritize Harry, so that Harry is waiting less time than a routine patient. And of course, shared decision making can be made available on Harry, and we can integrate. We've already integrated with Patients Know Best, and we can integrate with any patient engagement portal or any other sort of trust EPR systems. Now, in this instance, the system has highlighted that Harry doesn't have any significant health risks in terms of the anesthetic risk, but there is an anxiety as an issue. So the booking teams can adopt a smart booking process where Harry can be diverted to the play therapy team and doesn't really need a full pre-assessment, which saves on the capacity issues in the trust. And that can in turn help with increasing the productivity, where the sparse booking slots are really used to give appointments to those who actually need the pre-assessment. So in this instance, Harry is appropriately prepared, and he comes into theatre with the appropriate anxiety counseling. So he goes through the whole theatre episode with less trauma, and he has a much better patient experience. And of course, remote monitoring after surgery can also be conducted on RemCare. So you can prioritize the follow-up appointments depending on the needs of the patient and their recovery. So essentially, RemCare is a cloud-based digital perioperative assessment and management solution, which has been co-designed by clinicians and patients, and the West Midlands Surgery and Children has been heavily involved in designing this as well. So this is a system which allows an early anesthetic risk stratification of patients at the point they put on the waiting list to help identify pre-optimization issues, followed by regular 3-monthly contact to highlight issues which if the patients who are deteriorating on the waiting list, to help with clinical reprioritization. And RemCare is essentially also a robust electronic preoperative assessment platform, which provides the full preoperative assessment workflow for the pre-assessment nurses to complete the whole pre-assessment and improve the productivity in the service while streamlining the whole pathway and improving patient outcomes. And this is all very much in line with NHS England mandate for early risk screening and preoperative and regular follow-up of patients, of the patients on the waiting list. And of course, it complies with the NHS England and also the Association of Pediatric Anaesthetists of Great Britain and Ireland guidelines. So I won't talk too much about the results because Maggie and Barry can talk about their local sort of implementations, but essentially the early risk stratification allows the booking in line with the risk profile of the patient in the pre-assessment clinics, and potentially there is a opportunity to get the lowest risk children through a fully digital pathway, which can significantly release the capacity for increasing the productivity. In terms of the waiting list optimization, you can have cleansed waiting lists based on whether the patient really needs to be on the waiting list or not, and also a harms review, which helps in clinical prioritization. And some early evidence from Birmingham Children's Hospital has also shown a 7% increase in theatre utilization compared to pre-RemCare and post-RemCare in terms of minimizing the late cancellations and on the day cancellations due to clinical needs. In terms of the health economics, York Health Economic Consortium have conducted a health economic assessment, which shows that for every £1 invested in RemCare, there is a £7 efficiency gain achieved. So we're fully compliant with DTAC and all the UKCA markings as a software as a medical device. We're on various procurement frameworks. And essentially the ask for this forum is to help us in scaling RemCare across all the hospitals in the Midlands, to achieve a standardized and streamlined perioperative care for children's pathways, to not only help local productivity issues, but also standardize the pathways across the whole region and also help with mutual aid. Thank you so much.
We're going to talk about how did we define the problem, how did we meet Sandeep, where the budget came from, barriers and boons to success, and learning points that I think we've learned and perhaps Sandeep will recognise, and we'll just take it through that. So it's interesting, children's services lag far behind adult services, both culturally and clinically, in terms of preoperative assessment. And the reason why hospitals don't have these services is because the NHS refuse to fund them. And we've made lots of arguments over the last 10 years about parity of esteem and that children can really benefit from preoperative assessment. And that's now recognised in the NHS, and that's why the NHS surgery priorities stipulate that pre-assessment is required for all people having elective surgery, including children and young people. And so this sort of service allows hospitals to catch up where they may not have the infrastructure to take that on. Our problem and why our needs sort of chimed with Sandeep's product about 18 months ago was that following COVID, we have a pre-assessment service. We have about 15 nurses in it. It's quite robust. We're quite advanced in the process. It's well funded. We see about 14,000 people a year. We don't manage to see everybody because of resource challenges. We see between 70 and 80% of people. And we used to triage patients immediately after they would see their consultant surgeons and be given a surgery. And then we would triage them into needing to see a consultant anaesthetist, a dual clinic with a nurse and a consultant anaesthetist, a nurse on their own but face-to-face, so perhaps they might need some investigations and blood tests, or a more remote consultation, such as a telephone. And then as COVID came about, that remote conversation became virtual. And following COVID, that patient pathway completely dissolved. It was all remote. The way the patients saw their surgeons was remote, and they were listed just on a spreadsheet. And so our service didn't have a touch point as patients were listed in order to assess their fitness for surgery and their risks. Our hospital is very paper-based. It's going through a digital transformation, so it was very difficult to assess a patient's needs just by seeing that they had a tonsillectomy. They could have a tonsillectomy and be fit and well otherwise, or they could have major heart complications or respiratory complications. Very hard to guess, and so we weren't using our resources adequately. And so Sandeep's service that would digitally help to triage and put patients in risk buckets for us was really our key need, especially in the recovery period following COVID, as our patient numbers expanded rapidly, and we were finding patients in the wrong clinics, in the wrong settings, and it was frustrating. So that's where we sort of chimed, and his service was there, and it's developed, I think, in partnership as we've gone on. We've worked really closely together over 18 months, and so the technology platform was there, but how that was implemented in a patient real environment wasn't there. And there was a process of so the barrier to implementation, we couldn't just set it up and press go in our hospital. We needed to learn how to categorize patients digitally, and that process took about 3, maybe 6 months to get it really refined. And so that the algorithms that we were using, the patient questions that we were using, were putting people in the correct buckets, and we were testing that regularly. We'd have a senior nurse who was looking at how the patients were categorized based on the algorithms, and we'd have regular meetings. We're having weekly meetings with the RemCare team to look at questions, look at language, to understand what that meant, how patients or parents were interpreting certain questions. And it took us about 6 months to really nail that and get people into the correct buckets. It was a collaboration. It was very easy to start for us because the West Midlands Health Network supported this project. So we didn't have to go through a business case. They supported it directly with RemCare, which allowed us to start the whole process quickly. It minimized risk, I suppose, for RemCare because they're getting paid to help develop their product, but also it minimized risk for us because we felt there was some advantage in improving our abilities to see patients, but we weren't having to spend any money on it. We were having to spend time, and so that's where we got. that brings me to a learning point, actually. I think we'd have done better, Sandeep, if we'd have allocated some time or money to help from a clinical point of view. So you had time and resources allocated to RemCare and the development of it, and that was very good. But within our clinical team in the hospital, we had no time. And so we were trying to respond to Sandeep's team's questions, and sometimes we weren't very timely about it, and we could have sped up that process because we were just clinically stuck. It was a very collaborative process. The sort of building blocks of the product were there, but we learnt about the product as we went along. But I think Sandeep learned from us about how we managed our clinical pathways, and his team helped us understand our pathway better because we worked together, understanding the pathway, and when we adapted or learnt a new solution to the algorithm, new ideas presented themselves. So we were originally focused on clinical risk stratification, but actually through discussions and working together, we realized actually we've got a clinical risk strategy which is designed in the product, but also it's not new technology for Sandeep, but we've also got a stratification of needs, such as health inequality needs that Sandeep mentioned, that we could layer in and support our products, support our patients going through the service. An example will be identifying anxiety. You could be really ill or very fit, but anxiety is a separate pathway that we've laid into our systems, that we can refer those groups to different resources, learning disabilities, anxiety, or play therapy. Or have a detailed conversation with the nurses, but other health inequalities, such as can the patients even get to the hospital? And there was a separate charities budget in our hospital that would pay for parents to bring their children to the hospital, but they weren't able to identify those parents in need. But with this system, we could optimize other supports within the hospital, within that patient pathway. So I think that was key. We were initially skeptical, and I'd read lots of articles about apps and stuff, and in Ireland a similar product with an app that required downloading never got off the ground despite huge amounts of investment by the Irish government. And I was personally skeptical that a parent would have to, if they had to download an app, would even engage. But that's been proven to be wrong, and they do engage. And I think they engage because they understand there's a real connection between, it's a very patient-focused activity, and if you were shown our algorithm, you'd be surprised. It can be over 100 questions that parents have to answer if they have a whole plethora of illnesses with their child. But they certainly, most of them complete it in 5 or 6 minutes, but they could spend 15-20 minutes on the app answering questions, which is a lot of time and a lot of detail. But when we've asked them how they look at the app, they feel more confidence in that we're taking their problems much more seriously, and they will engage with it. And we've got a sort of 60 to 70% usage where parents will complete the questionnaire. We have a full picture of their clinical details. And the messaging, as long as the messaging is correct, and we worked on the messaging a lot, how they receive that message from the hospital, how it's important to them, is a really important learning point. Timing is important. So the timing was right for us. We were seeking this product. The time was right because of NHS requirements were pushing us to have to do this. And timing is right because Sandeep and his team were developing this product. So timing is really, really important. Working within the hospital, it's interesting because there's a core team that are involved in it and bringing it out into the clinics and getting the nurses to use it. And there is a lot of resistance on the ground about using new digital products. Doesn't matter how simple it is, it's just another thing to open, another thing to use, and people really don't like it. And that was a barrier for us to use widely. And the only way around that actually was sitting with, so you had some nurses who were used to it, who'd been in on the development meetings, and myself. And the only way really to get other nurses to use it was to sit with them in a clinic, look at the RemCare results, and then read it through with them, and they go, oh, I know everything about this child before I've even. So it speeds up their appreciation of what child they're going to see. It speeds up their clinic appointment, and then they receive that benefit. But they only get that with confidence of sitting with them for 1 or 2 clinics, and then they sort of use it on their own. And I think that's an important thing. We've gained confidence in the way we use the product over the time. So this idea of it being funded by the ODN allowed us to gain confidence and work differently. And that has allowed us to actively change some of our pathways so we see patients differently because of the product. That's where some of the savings come in, and the savings come in mainly in I think there's marginal gains in theatre utilisation, and I think there is a degree of error there, but the huge savings is in nursing time, and that's very costly. And we've gone to equivalent hospitals where they're using about 2 or 3 whole-time equivalent nurses to triage and manage patient pathways, whereas essentially we have a senior nurse who manages the RemCare platform, and it saves a lot of nursing time in our clinics and allows us to see more patients in more clinics. That's what we've learned from it. So I don't know, I hope I've covered a wide range of stuff. If there's any particular questions anyone wants to ask, go for it. Oh, integration. I just want to mention integration. It was a standalone product, a standalone development cycle. And I think that helped us because we could just get going. There's no barriers to integration. But later down the line, we did some workarounds around some integration, so we could upload lots of patients very quickly, and that helped us to roll it out in our service. But now our challenge is to get the hospital to integrate it into the rest of its digital service. So we know the benefit of it, and that is the challenge for us to convince the hospital, but also Sandeep to do it. But I think probably the product's in a different place, so you could probably go to a hospital now and say, well, actually, you know, there's you've gained a lot of evidence from our site. You've got lots of data. You presented that on this previous slide, so it's a much easier process, I'd imagine, going to another institution. I'm mainly here to talk about my experiences of the NIA and my experiences as a fellow and as a clinical entrepreneur. So I'll just dive straight in. So for those that don't know me, I'm a doctor based over at Royal Derby. I'm also the associate CCIO for Derby and Burton. But I've been in and around the clinical entrepreneur space for several years, having gone through the NHS England Clinical Entrepreneur Programme back in 2017. So most of my time is actually spent within an organisation that builds what we call NHS ready software. And we built several different solutions with several different NHS providers. And one of those was with Somerset Foundation Trust, and it was around a maternity solution that actually controlled the response to an obstetric emergency. And it was this solution that got us onto the NHS Innovation Accelerator. So I just wanted to talk around how our vision for that solution has changed, how our ability to work within the NHS infrastructure has changed since being on the NIA, and then all of the other stuff that comes with an accelerator like the NIA. So I guess the key thing, and Jack's probably covered up a lot of this already, the key thing around being on the NIA is that you have to have traction, and you have to have evidence, and you have to have regulatory compliance as well. So those were the 3 things for us that were key, because we knew that we had
a lot of that under our belt, and we had enough traction to be able to get on the NIA. And that for us was one of the key things that we wanted to get out of the accelerator, was the acceleration of the solutions adoption within frontline medicine or frontline healthcare provision. And we were really struggling anyway, because I won't go into too much detail around the product itself, but effectively you've got an iPad next to the parent's bed, and you can trigger a postpartum hemorrhage from that tablet. And then at the nursing station, the roles associated with that emergency come up so that we can allocate roles from outside the room, which creates better situational awareness, faster response to theatre, and then improved auditability and reportability, which medically legally was phenomenal. The problem is getting the iPad stuck to the wall. The rest of it was easy, but actually going through a state to get access to pinning an iPad to a wall was taking months. So I said to Jack, I said, look, Jack, I need to think about other ways to introduce this value into the NHS. And so the NIA opened up two doors. The first was grant funding. Obviously, Jack and Mindy are front and center of a lot of opportunities for support funding, things like that. So they actually helped us win an award. And I guess part of the help is just by being on the program and it being a recognized program for good innovation. So just being on that program enabled us to write a really compelling grant application. And we won some money from Innovate UK to build an extra module to the system, which allowed for automated follow-up after birth. So essentially, once a patient had gone through ERA systems, which is the name of the solution, you put in their patient details, and within 12 weeks, they receive a questionnaire to be able to assess their risk of PTSD, which is a very timely thing, given both birth trauma inquiry outlined that 1 in 20 births have a risk of trauma. And so that then lowered our barrier to entry massively, because we now had a pure software solution that was able to support these birthing parents, and then we'd retrospectively tell them about ERA assistance, which is the longer term transformational innovation. So that has just turned the whole opportunity on its head to really support the end-to-end process of an obstetric birth. And if you have any questions, I won't have time to go into it, but if you have any questions about the solution in greater depth, I'm more than happy to meet with anyone and share details, or Kev and Tanya can share my details. So that was the first opportunity. And then the other thing that I really want to highlight around the NIA was the introductions that gets made, because Jack and Mindy have a fantastic network and again are in the middle of the innovation landscape, and made a really interesting introduction to Helen Bolsden, who is the interim CNIO at NHS England. And having met her team, they said, well, could this software be used in other parts of the hospital? And I said, well, yeah, where are you thinking? And they said, well, A&E waiting rooms. And being an A&E doctor by background, I was kind of like, why did I never think about this? And that doesn't require estates, because there's no drilling holes in walls. They're very much kiosk-based, so freestanding. And now what we're piloting at Worcester, only 2 months after concept, we're now piloting the ability to support patients in waiting rooms by giving them the ability to trigger for mobility assistance. I feel sick, I'm in pain, I'm bleeding, and the triage nurse, because by the way, there's one nurse looking after up to 60 patients in a waiting room, which if CQC saw that as a ward would be shut down tomorrow. We are now looking at how we can support fit to sit patients and waiting room patients through this new innovation that was never designed for that purpose. So diversification was one of the biggest opportunities that came out of just socializing the network, spending time with Jack and the team. And that has now enabled us to support many more patients. And obviously, off the back of the Channel 4 Dispatches documentary, which I'm sure many of you will have either seen or heard about, we're now providing ERA waiting is the new solution to A&E waiting rooms free of charge for a small period of time, because it's been sponsored, given the size of the problem that we're now seeing. So that's really what the network, the accelerator, is about. It's about individuals like me talking about the opportunities, but also the challenges, and someone somewhere going, I think we can do something about that and save that. The other benefits of the network are, the other benefits of the accelerator is the network. Phenomenal people, like-minded individuals who all come together to support one another, get into new areas, identify challenges. So, you know, for example, if I was aware of there being a clinical pathway issue that I thought RemCare could solve, I'd be able to highlight that, and we'd be able to talk about that. And the other opportunity is the Health Innovation Networks, the ability for the NIA to push you into the new Health Innovation Networks. I could see Nick's on the call, and Nick and the team have been fantastic in our development. It's all about connecting us to all of the other HINs across the country to really spread awareness and adoption of that solution. So we've had, it's been just over a year since we've been on the program. Must have been up to a year and a half actually, but we've really benefited from engaging with other people, being pushed in all the right directions by Jack and the team, and then just by being able to immerse ourselves in the world of NHS, which even as an NHS clinician you think you know, but it goes a lot deeper, and there are a lot more layers to uncover that quite frankly often a frontline healthcare professional cannot get into. So yeah, that was my 2 cents really.